This week on the BackTable Podcast.
I try to do the measurements, measure really the height of the ears, like the length of the ear, especially in microtia if we're going to reconstruct the other side. But in terms of, for otoplasty for angles and the height of the mastoid, that was something I was going to ask you about, Charlotte, too. Like when you're doing, just say, a unilateral, are you just trying to match it to the other side? Or are you measuring and then trying to get to the measurements? Some people will kind of dot off certain parts of the ear and then measure its height off the mastoid and then try to adjust it to equal the height of the contralateral side, and I just have never really found that helped. I would write down all these numbers and never end up using them and then just go by what it looks like.
Hello, everybody, and welcome to the BackTable ENT Podcast. My name is Gopi Shah. I'm a pediatric ENT, and today I have two amazing pediatric ENTs here with me. Today I'm joined by my co-host, Dr. Jason Qian. He's a pediatric otolaryngologist at Rady Children in San Diego. You guys may remember Jason from BackTable episode 213, Ear Molding in Infants. How are you today, Jason?
I'm great. Thank you so much for having me back. Since the last time I was here, I've been doing a lot of otoplasty, microtia reconstruction. And so thank you for inviting me to kind of co-host with you. And I'm really excited to talk about otoplasty, learn Dr. Célérier's techniques, and maybe apply it to my own moving forward. I have some cases. I did bilateral otoplasties yesterday. I have some cases next week, microtia reconstruction next week.
Awesome. Well, let's introduce our guest. So we have Dr. Charlotte Célérier. She's a pediatric otolaryngologist at Neckar-Enfants Malades Hospital in Paris, France. And she is here today to talk to us about otoplasty. Welcome to the show, Charlotte. How are you?
Yeah, fine. Thank you for hosting me. I hope that my French English is going to be okay.
It's better that we're doing this in English than us doing it in French.
Yeah, your English is better than my French.
Exactly.
Yes.
Your English is probably sometimes better than my English. But
yeah. Thank you.
So can you first just introduce yourself? Tell us a little bit about yourself and your practice, how you got some training in otoplasty.
Yeah, sure. So I'm an ENT surgeon, and so I'm working at Neckar Hospital. It's a public hospital in Paris in France, and I'm doing otology, plastic surgery in the microtia team. So it leads to otoplasty too. So that's how I've been training.
And was otoplasty and microtia part of your fellowship training? Is that something you had a lot of exposure to in residency?
Yes, because my chief of department is built to the microtia team, and so she was doing it. And at the end, she needed help in her practice. And so I like this field, and I started to train with her, and I specialized in this field. And so the more you do, the more you're referred with all type of ear malformation. So yes, I train as a fellow, then as a resident. So yeah.
And who's part of your microtia otoplasty ear team?
We are a big team. We have several parts like airways, otology, cochlear implant, robotic and consologist surgery. But for the microtia team, there is just my former head of department, Françoise Denoyel, and me. And so we are kind of training a new one. So she can help us, I think, if she likes it in the future, because we are only two, and my chief of department is going to retire soon. So I need help.
For both of you guys, how are patients usually referred to you? Is that something that comes in? Is it difficult to start getting those referrals? Is it from pediatricians, self-referred? Do patients find you?
Do you want to start, Jason, maybe?
Sure. When I joined our practice in San Diego, there was a little bit of a vacuum for external ear, and that was one of the roles I was brought to fill. And then when I began the ear molding practice, all the pediatricians, they sort of started seeing that, and the business has gotten pretty busy with ear molding. Now we have 2 physician assistants in a dedicated ear molding clinic to help take that volume. And so either the pediatricians direct refer to me, sometimes the kids end up getting funneled through the ear molding clinic. And then also, now that we've started the microtia atresia program within the division of otolaryngology, as you said, Charlotte, the otoplasty sort of comes with that. And so my partners also send all the external ear to me as well.
Is that similar for you, Charlotte? Or
yeah. As I do ear molding too, of course, the pediatrician of the maternity sends us the little ones, and after as I'm known to do otoplasty and microshot surgery, I'm referred to do that. And my colleagues tend it to be, but it's kind of competitive in France because you have to build for otoplasty between maxillofacial surgeon who do it and plastic surgeon too, and practice in public. So sometimes I have patients that are coming because they first see surgeon in private practice and the price was too high, and so they come to see in public what they can do, what they can have.
Yeah. So as we get started into our discussion, I thought it would be good to just kind of go over some terminology. Can you give us some, discuss some of the terminology and how you explain it, whether it's to medical students, residents, to colleagues, to families of the different type of ear abnormalities?
Yeah, so prominent ear, that's the ears that's easy, that stick out too much. Or there is a conchoidal ball that is a valgus too much, or a poor anti-helix folding. So that's the simplest part. Stahl's ear, that's more difficult to understand. It's an extra fold in the scapha that leads to a third cross, and it results in a pointed ear shape, like an elf ear. And this, if you can see these babies really early, you can mold the ear, and it's really better than the surgery. Surgery is not, it's kind of difficult. So if you can catch them before, it's really better for them. And after you were asking what Cryptotia was. Cryptotia is like you can't see the upper part of the ear. It's buried under the skin. And when you gently pull out the ear, you can find a complete cartilage. So that's a malformation that you can see usually. And it's not problem of cartilage. It's more like skin problem and muscle problem. And after we have microtia, of course, that's the congenital deformity with an underdeveloped ear. And so you can have minor defect to complete absence of external ear. And usually you have moderate to severe transmission hearing loss.
And, in terms of when patients present to you, you had mentioned the maternity. So a lot of times outer ear abnormalities, the babies will present at birth. I know, Jason, you had mentioned on our last episode, 213, that really it's best to get those babies into your clinic for ear molding before that 6 to 8 weeks, just because that maternal estrogen, it's in the baby's bloodstream to help with the pliability of the cartilage.
Yeah, it becomes much less effective after, essentially, I tell people I won't put on the molds after 6 weeks, although there's a little bit of wiggle room, but that's just to get everybody in. I'd love to know, Charlotte, for your patients after the ear molding, or if they're like an infant that's too old for a mold, what is your sort of follow-up plan for them? For me, if they have microtia we'll see every year until definitive reconstruction. But with the babies, I'm kind of telling them, the parents, like, we're not going to do anything for this until at least age 5 for me. I don't really want to be doing an otoplasty younger than that. And ideally, I would wait a bit longer than that. And so I just sort of send them off and be like, come back if this is still a problem for you when the kid's school age. What's your sort of philosophy and practice on?
Yeah, I think that the practice is the same, meaning that for microtia, we follow them because we have to follow the hearing and how the language is developed and if they need hearing aids. So we really follow them close up following. So that's one part of the ear microtia team jobs. And after, for all the molding ears that we do, when we can't do it properly or it's too late, I always tell the parents that I want to see the kids when he wants to have something, not the parents. So
that's a good point.
A good point. Yeah.
I'm gonna write that down.
So if we're the pediatric ENT and the baby's in our clinic and now they're like, 3 months, we know that we've are too late for molding, maybe not refer them to you guys until they're interested, or at least 5 years of age. Does that sound kind of reasonable?
Yeah, even 6, 7 years old, before they never want to have something, I think. The parents want, but in France, we are really conservative. The children doesn't want to have surgery. They don't.
In terms of the parents come in, they may ask, how did this happen? Are there certain risk factors? Are there genetics play a role? Like, our uncle had this and had to, or birth trauma. Are there certain things that you ask or have to think about, or how do you explain it?
Yes, we always try to see in the history of the family. If there is something prominent ear, usually you ask, or the mother of the father, they had an otoplasty at one point, or they don't, but you can see they have prominent ears. And after for microtia, we don't know everything about microtia. We know something happens, but we'll let them to the genetics colleagues so they can do genetic research. But when there is no syndrome, we don't find anything. But I always tell the parents there is something, but today we can't explain everything to you. Maybe later, but today we can't.
I say a very similar thing. I think there are some, syndromes that are associated with microtia, like Treacher-Collins, and that's usually pretty obvious, and they're being followed by the genetic team already. Then the kids with either isolated microtia, although some geneticists may say, that's just like very mild OAVS, either way, that you're not really doing anything else because it's isolated. And I tell those families, we don't have a gene that we have identified. We do know that it sometimes runs in families. We do know that in certain ethnic groups like Asian, Latino, Amerindian populations, it is a bit more prevalent. So you would sort of think that there's something there, but we, like Charlotte said, we don't really have the answers.
In terms of your physical exam, are there certain measurements? Do you have calipers? Are you taking photos? How does that work for you?
Okay, so I'm really bad at taking measures. I'm never measuring. But there is ideal measures, of course, of the auriculocephalic angle between 20 and 30 degrees, and the millimeter like 15 and 20 millimeters between the scalp. But I don't do it. I do photo always because it's for expert medical evidence. If you do plastic surgery, you need to have pre-op photo. So I really do that from front side, lateral side, upper, lower angle, 3/4 face. And I always do that, but no measurement.
I try to do the measurements, measure really the height of the ears, like the length of the ear, especially in microtia, if we're going to reconstruct the other side. But in terms of, for otoplasty, for angles and the height of the mastoid, that was something I was going to ask you about, Charlotte, too. Like when you're doing, just say, a unilateral, are you just trying to match it to the other side? Or are you measuring and then trying to get to the measurements? Some people will kind of dot off certain parts of the ear and then measure its height off the mastoid and then try to adjust it to equal the height of the contralateral side. And I just have never really found that helped. I would write down all these numbers and never end up using them and then just go by what it looks like.
Yeah, usually when I do measurement and forget, I'm not writing it down. And after, I just like to see on the front in the OR, what does it look like while I'm doing the stitches and how does it look. But unilateral are more difficult to do the symmetry between the two ears. That's right.
So let's kind of get into the management. Let's say you have a child who is 7 years old, and now at this point they're ready for something to be done. Let's say it's just really they're really prominent ears. My ears are big. When do you start considering surgery, and how does your decision making between, you guys had mentioned unilateral versus bilateral. We talked a little bit about age. How do some of those factors play a role in timing, and who would make a good and patient selection as well?
Yeah, I think that the child must be really motivated. He really needs to. Sometimes I see them a first time. I explain all the surgery, the risks, the post-op dressing and everything. And I never have a date for the surgery after. I always ask them to call me back. If they really want to, I give them a paper where everything is written down. I show pictures, pre-op, post-op pictures, so they can figure out what's going to be, how does it look. And after I do the surgery, only when they're ready, and I see them another time to take the picture, etc. For otoplasty. For microtia patients, it's a longer process. So
I think for me, for otoplasty is similar. If it's like a younger child and the parents are here more on like a information gathering, or like the pediatrician refers like, oh, you could see someone about that. It'll be, all the information, and, let's make a follow-up appointment distant to see when you're ready, come back. But then there are, the teenagers that come in, and it's been like, I've wanted this for a long time, and it's because I don't like the this fold in the ear that's making me look like an elf ear, and everybody's really motivated, or if it's like really specific. I don't like how, my ears are really forward. It's making me self-conscious. I don't wear my hair. Like the boys like sometimes have like long hair because they don't like to wear it. Makes wearing sunglasses sometimes hard. If it's a pretty mature kind of complaint, then that's something we can go ahead and be more confident in booking.
Yeah. Does prominent ears, for example, is it easier or harder, or does it matter whether they're 7 years old versus 18 years old? Like, is there any change with the cartilage or recovery or outcomes with something like that? I don't know.
I would say except for the scarring and the risk of hypertrophic scarring for a teenager, I use the same technique, even if they are, after it depends on the cartilage, is smooth or stiff, but I think the age is not an issue.
I think it's all hard. It's always hard.
It's always. So are there patients where their surgery is not an option? Maybe it's the 17-year-old that's in your clinic. They want it done, but maybe they're a wrestler or they're playing basketball, or contact sports always comes to mind for me. And I think it's just because my kids are in that age range now. But, who is not a candidate for otoplasty?
Yeah. In France, rugby is really popular as a sport. So I don't do otoplasty if you want to be a professional in rugby or in MMA fighting or whatever. I explained that to him to say that you'll come back when you finish your passion about sport, but it's too risky.
What about you? Any other contraindications I think of, like maybe a child, maybe with special needs or developmental delay that might have a history of like head banging? Does that come into role? Is that not really common? Or
Oh yeah, I mean, I think what the overall, because this is like kind of quality of life surgery, and if it's like a developmentally delayed kid with head banging who's probably not personally motivated to do this is probably from the parents. I think that kind of expectation is I haven't had that situation, but that's probably something I wouldn't offer. I think when it's a really subtle finding and it is unlikely for me to realistically make a meaningful difference, I would say this is probably better off that you sort of stay as is, that your ear looks good to me is what I would say.
Yeah. It's important to say that some patients that are really expecting something that you can't give them. And after we propose sometimes psychologic evaluation too, when we see that it's more like a problem of psychology and the way they see themselves and self-confidence. So we are lucky we have some psychologists to help us with very, really few patients, but it can help.
Yeah. So let's say we are planning for surgery. How do you have a spiel? Like, how do you counsel families in terms of expectations or the process? You'd mentioned, Charlotte, that you show them pictures and, the post-op care. Talk to us a little bit more about that.
I always explain everything about the surgery and how it goes. It's in ambulatory, and after for the dressing, we can speak about that maybe later, but it's not a long time dressing. And after, I think I explain everything before so they can know they're not afraid of the surgery.
Yeah, I do the same. If I take a skin graft, for example, because that's what I like to do for Cryptotia, we sort of talk about all the incisions. We talk about the dressing, the time I expect them to not go to school. And we could talk about that later too, kind of our protocol. I'm really curious about yours, Charlotte. And so find a time that is like right for them. And, the complications, I always say the biggest complication here is dissatisfaction. It might not be exactly what you envision. There's only so much we could do. Here are some pictures. And if this is okay with you, we could go for it. And then the other thing is like sometimes with time, and I haven't been in practice for long enough, but in otoplasty, sometimes for prominent ear, it'll become prominent again. And knowing that is something that may happen, but we're willing to try, then if everyone's on the same page, we go for it.
And this is always under general or sometimes under local? You'd mentioned ambulatory, so I imagine it's in the outpatient.
Usually it's under general anesthesia, but I always propose local anesthesia. Usually in children, they don't want it. They don't want to have local, but it's a possibility. And after, as we are in a university hospital and I have to teach also resident and fellow, I prefer to have a general anesthesia so they can work on the ears. So
That's very brave that you would even offer that under local. That is not something I offer. It's like, this will be general anesthesia. Yeah.
So let's get into surgery. Go ahead. I'm going to let you ask a little bit more of these questions
Sure.
as you perform the surgery.
Yeah. So let's start from the beginning with draping. Like, draping for otoplasty is this actually kind of a big thing. People even write papers about draping, because you can imagine if you want to prep out both ears to the point where you're actually prepping behind the ears, hair management.
It's like, is it the whole face?
Yeah. So how do you do it, Charlotte?
Okay, so for the draping, sometimes I shave just a little bit around the ear, not that much, or I braid if they have long hair, and I keep all the face in the draping. So I have a sterile plastic drape on the face, so I can see the nose, the eyes, and after I put drape behind each ears and front and under the nose.
Do you do stapling or like a head turban with a towel? Or
no, I never managed to do the head around. They're always everywhere, so I just I can show you, but I put one drap here, one here. There is the sterile transparent draping on the face, and after there's a drape here. But I turn the head while the fellow or the resident is draping, so the drape is going really smooth and you can still move the head during the surgery.
And so is the face prepped, or is it just that the face is also prepped?
Yeah.
Okay.
I do it quite differently, and I am very interested in seeing your pictures and maybe considering that. Like, the one I did yesterday was a boy with medium length hair, which is like the hardest. I actually tried not to shave, but maybe I will start to shave because at the end the hair was everywhere. I also cannot, do you do a French braid to keep it out? I probably should learn how to do that. I have a daughter now and I'm really bad at doing hair, so I cannot French braid. So what I do is I first take a bunch of Surgilube and I use it as hair gel to pull the hair back. Once that dries, it's not like hair gel, but at the beginning you can at least control it with Surgilube. And then I do prep the whole face, and then after the prep, I lift and put a flat sheet underneath, and then 2 towels that I will do a turban, but it's like 2 layers of turban, one to sort of go behind the ear. And, I try not to shave the hair, but I do staple. I do use a lot of staples in the scalp to try to keep that down, and then another turban layer to cover the forehead just to keep and above the ear. And then once I put the split sheet on, it just goes straight down, and that the turban sort of controls the hair, and I can then move the head. It's not perfect, so yeah, I'd love to see some pictures of Charlotte, your prep, and
I can.
Maybe I'll move something.
But I think that I don't know if. Because I'm doing PPE for microshell reconstruction too, and when we are draping, I leave all the hair in the draping. So if you prep everything, I think it's okay. Yeah. Maybe we should just do the same and just put soap on the hair too, and after it's inside the dressing.
Yeah. That's what I intend. And the girls with the long hair, it'll be a high ponytail and it'll be wrapped and it'll sort of come out to me. And I just sometimes, if it is really long and beyond the towels, I'll put like a head drape on just so it's not in the field. But it's always just the small hairs like right beside, the ears while you're like closing and you're trying to put Dermabond on. So like yesterday I took the staples out to put the Dermabond and my steri strips on. We could talk about your dressings afterwards. And then I was getting the hair on the derm. I was like, oh my God.
So let's say you're prepped. You have in your field the face, your ears, no hair because it's Surgilubed and braided and stapled.
Controlled somehow, yeah.
Do you have like a template that you make? What's next? How do you start, and how does it change if it's 1 year versus 2?
When it's 1 year, well, you make the only ear, but if it's, cauliflower ears, or if you have a problem with the size, I always do a template even for otoplasty, just to see if when you do the otoplasty is gonna match the other side. So I do it before and Stahls, and after I put it between two tegaderm, and so I have it Stahls after on the table if needed. And after I start, if it's both sides, I start with the most prominent side, and after I do the other side so I can match it.
Yeah. I would say most commonly it's prominent ear, so I don't make a template for prominent ear. But for the other ones, like I'm curious. When we should probably talk about prominent ear first, and then we could talk about your technique for Stahls, like how you handle the bar. Do you cut it out? Does that create like a smaller ear that you would then want a template for? And then, for cauliflower ear too, I've been very limited in what kind of cauliflower, and I'm not doing like full cauliflower ear, but like there were, some kids with just like a little bit of cauliflowering that I would address. And so for those, I actually hadn't made a template because I wasn't doing a big size reduction. But yeah.
In terms of technique, you read about cartilage sparing, cartilage cutting. Can you kind of go over that and, what your preference or when you consider using the different ones?
When I first started doing otoplasty, I was doing cartilage cutting, like converse technique. But now I'm most doing like mustardé and furnace, and I mixed both. And I almost don't do cutting anymore, because I think that after the ear is more like with edges that you can see too much. I don't like it. It's less natural, I think, for the result.
Yeah, I have never been trained in a cutting technique. I've never seen it or tried it. I have also heard of some people, they use a drill to kind of thin the cartilage, to decrease the integrity of it. Also haven't tried that. I do for prominent ear rely on a mustardé and a furnace, and I think like just before we get there, like the incision would be you ellipse out some skin over the concha. You make the posterior limb of the skin excision will be in the sulcus, and then the anterior would be a bit over the concha, especially if you're going to furnace and do a conchal setback. That kind of fits well. Is that something you do when you make your incision?
I don't, for the skin incision, I put it behind the ear and not in the sulcus. That's funny because every time I take skin for the microtia for the second stage, I take it in the sulcus. But with my otoplasty, I put the skin, excise the skin more upper behind the antihelix, in fact. Yeah, what's going on? But I'm just like you. I'm doing the posterior bed so I can put the concavo inside, the stitch the concavo, and after. And I don't know if you do that. I excise the skin, but I keep a small subcutaneous fat that is attached to the skin on an anterior-based flap. So when I put back the skin, it can recover my stitches to avoid extrusion.
Oh. That's a really great point.
I really changed that a few years ago, and really, as I'm using not absorbable stitches, it's useful.
Yeah, that's a really, really great point. When I'm making the skin excision, I'm always sort of thinking like, is there anything I should be saving? But I've been going right down to sort of perichondrium. But that's a really great point to leave some of that connective tissue underneath to cover the furnace stitches, because I use a Merceline for the furnace. What do you use?
I use Etibond. It's a non-absorbable polyethylene.
Okay, Merceline is also a non-absorbable polyethylene suture, so it's probably very a braided suture. Yeah. So for your mustardé placement, what is your technique for the placement? Do you like the pins? I had been taught pins and then tattooing where the pins came out with methylene blue. That's how I was doing it first, but I've actually sort of switched over now to doing Prolene guide sutures. What do you do? I
put needle with no methylene, with no tattoo, and after I do the stitches. And usually when I don't have any resident or fellow, I do it like without the needle, but I just see where it goes and where it looks like. And I start in the middle of the antihelix, and after I go up.
Wow. That I think that's like a lot of mastery on Charlotte's head to be able to see, it's sort of easy on the front to see where you want it, but then I always get really disoriented when I go into the back to be like, where do you actually have to place it to?
So I put two
to
needles.
Make it look like in the front.
Yeah, I put two needles. One where I want it to bend in the concavo and in the scapha, and so I keep the needle, and after I do the stitch, and I take off the needle after I go up.
And you can see the needles.
Yeah,
from the backside.
Yeah, you're from the front side. You put the needle in the skin through the cartilage, and when you go on the other side, you see the needle that is pointing through you. So you take it with your pins.
Your forceps.
Yeah, and after you do the stitch.
Yeah. What I started doing was a Prolene guide stitch. So I, in the front, make the shape I would like with a mattress Prolene, and then tie those down. And once I'm happy with the placement of the 2 or 3, then I go in the back, and then sort of similar to where you see the needles come out, you see where the Prolene comes out, and then I've been placing it. I've just found that was a little bit easier for me. And so what sutures do you like to use for your Mustardes?
I use for both Mustarde and furnace. I use the Etibon.
Okay.
Yeah, Etibon.
So it's a braided.
Yeah, 4 Etibon XL. Yeah.
I do a 4.0 clear nylon for the Mustarde, and then a 4.0, actually a 3.0 Merceline for the Furnace. And that was just how I was trained to do it.
Yeah. Me too. Yeah, I'm reproducing what I've learned.
Exactly.
Is it similar to so you have your needles in where you're going to put your Mustarde sutures. You're putting in your ethibone sutures. Is it kind of like airway surgery where you tie them down all at the same time, like put your sutures in first, and then once they're in, then you tie it? Is there any trick to that? Or
I like to put 2 and then together do the stitches so I can see how much I can tie it. Not too much from the front side.
Got it. Okay. So you're kind of like airway, you put the sutures in and then you'll tie them down and then decide tension, and then if you need to add another, you can.
Yes.
When I did the pinning, I used to do that, but then now when I do the Prolene guide sutures, it's already kind of tied down from the front.
Yeah.
And so then I actually, just because it's been easier and they're off tension, I just tie them as they come on the back now because of that. So.
And then at the end, you just take your Prolenes out.
Yeah, you just got the Prolenes out from the front.
Is there any variability between like how it looks once the Prolenes are out from the Merceline and the other like permanent sutures that you're using?
Minimal, because you're not going into the same hole as like the Prolene was coming out, and you're not going to the same hole as the needle coming out, so you're going close to it. But if there is any variation, then you have to go and figure that out again. There shouldn't be much.
And is there any role in overcorrecting or, like you ever, for the surgery, like, let me tighten it just a little bit more, or pull the ears back just a millimeter or 2 more, or because after the dressing and over time, it's going to fall back. Like any tricks on that or not really?
I don't like to overcorrect it. Yeah, I prefer that it's not enough and that they're not happy, and maybe you might go back to the OR than too much because it's more difficult to revise.
I don't intentionally overcorrect, but sometimes it does look a little bit overcorrected. But then when I see them in their 3-month follow-up, it always relaxes a bit, and so.
And before we get to some of the other deformities, I should have asked this earlier. What instruments do you always have? What's on the Charlotte Célérier Mayo?
Table.
What's on your back table? Yeah, what's on your back table? What's on your instrument list?
I will say sharp scissors, because I like for dissection, the 4 Etibon for stitches, and needles, small needles. That's all.
Like a 27, 25, what size?
Yeah. The really, in French, it's intradermique. It's they're orange. Yeah.
Okay.
Yeah, I pretty much minimal. I think like any plastics tray will probably have what you need. Just knife, sharp scissors for dissection. Sometimes I like a caudal.
Oh, and crochet. I don't know. Hooks.
Yeah.
Yeah.
Oh yes, hooks. Yeah. Yes.
And then any tricks for your local anesthetics, like for lidocaine, without hemostasis? What do you like to use?
Yeah, I usually do Qian with hemostatic, yes, for first. And after, at the end, I do ropivacaine. So it's a long-term anesthetic. So that's nice. They're really not painful at all.
Yeah, similar. And I think the trick would be, you're not just injecting your incision/skin excision. You want to hydrodissect the posterior ear, right, because that's gonna you're gonna sort of dissect all the way up to the helix. So to sort of help you with that.
So let's go through sort of some of the other deformities. We'd mentioned Stahl's ear being a little bit more difficult to have to repair. Talk to me a little bit about how that goes. And are you removing cartilage?
Yeah. Stahl ear are really difficult to correct. I think sometimes it's really rigid, so you have to take off the cartilage and you do like wedge excision and you reduce a little bit the ear. And sometimes it's kind of smooth and you can just do an otoplasty and it's okay, and that's the simplest way, but it's not always like that. Usually you have to do a small reduction of the ear, so you have to see if it matches with the other side.
And when you do that, do you excise like the anterior skin as well, like a composite resection of the wedge?
It depends. It depends how much is the crus, and sometimes yes, sometimes no.
Yeah, Stahl's ears it can be so variable. Like the last one I did was a very broad bar, if you will. It was just as if the scapha was everted, and that was like something different than I'd ever seen before. And so I was looking in the Fermin textbook, and she had shown this, like if you make a crescent within the scapha, then you could try to, and then you do a wedge excision of the helix to try to bring it up. And then, and it, when I was in the operating, I was like, but it wasn't as looking as good as I had envisioned, and I lost my mind and actually sewed in a bolster to heal it. And I was like, maybe this was risky. I put her on antibiotics, but it actually looked pretty good afterwards. I don't know if I'll do it again, but I think every Stahl's ear is different, and it's really challenging.
Yeah, and sometimes in Fermin's book, she also sometimes do like rib for Stahl ears. So I think it's maybe hard, but
yeah, it's a bit extreme to do a rib for a Stahl's. Yeah.
And talk to me about cauliflower ear. I don't know, in my mind, I'm like, I think of the curled up, the cartilage is bad, the skin is probably not that great. How does that, what are we doing? What are the goals, and how does that work?
Yeah, in children, we don't have that much, but I think it's really, sometimes you have to drill it, sometimes you have to excise, but keep the skin, and I put bolster, and after the result is I always tell the patient that the result is not going to be as nice as before. I think you have to inform them of that.
Yeah. Honestly, I've been trying to avoid it because, as Charlotte said, in kids, you're not seeing like the full wrestler, like full cauliflower. It's usually just like a little bit of like a cauliflowered hard part. Sometimes there was one that I did where the concho bowl was the cauliflowered part, and it was actually causing like EAC stenosis and causing like OE. And so that, for functional reasons, I did that. And I'm really happy with the results. I, incised right over it, raised skin flaps, and then cut and drilled, the concha out. Did this under like an otologic operating microscope, and then sewed the flaps back together and then put a bolster in. But yeah, for helix, I haven't done very many, and I think I'd be a bit hesitant. It really would depend on, what the goals are.
Motivations of the patient,
Yeah. And Cryptotia, how does that go?
I mean, there's two ways to do Cryptotia. There's like these like Z-plasty, ways, and then there's like the kind where you put a post skin graft, which is my preferred way. Charlotte, what do you do?
My preferred way is to do a small skin flap with muscle, and I flip it from the upper side, so the skin from the posterior part is going in the upper side, and so it's kind of clever. Yeah.
So is it a rotation, like pedicled rotation skin flap? And then do you take down the pedicle later?
No, you have enough to take the muscle in the mastoid, and so you just flip it without cutting it, and it just comes really good.
That's very interesting.
We wrote a paper on it with the drawings. It's more
Okay,
more
I'm gonna look it up.
Yeah, more simple to understand, but it works really well. And usually, in Cryptotia, they have usually a valgus of the concave. So when you take off the skin, it's come better too. And sometimes I put a stitch on the concave too, if needed, according to the other side.
I see. I'm definitely going to consider that.
Mm-hmm. And I put a bolster on it for 8 days. And after, I usually mold the auricular sulcus, like we do in second stage for macrotia, for at least 1 or 2 months at night, only at night. So with the retraction, it wouldn't stick in. Yeah.
Yeah. The way I was trained by my Trong, also similar technique to second stage microtia, but we are putting a skin graft behind and then sewing the bolster in as if it was a second stage microtia. And then I have not been molding, you could put these like kind of silicone ear kind of pillow things on afterwards. So I think that probably is a really good idea. And so how long do you do that for afterwards?
1 month, just at night. Yeah.
Yeah. So I guess that leads us to, we haven't really talked about dressings for even prominent ear. For what I have been doing is I actually put a mastoid dressing on after the surgery. And then I tell them to leave it on for 2 days. Sometimes they fall off. But what I do make the parents buy are neoprene headbands, which there's a product called the Ear Bandit that you could get on Amazon. And what's actually designed for is for swimming, to keep earplugs in while swimming. And I tell parents to get an otoplasty surgery, you must go and buy, the headband. They're like less than $20 on Amazon in the US, and there's all these different sizes and colors, but I tell them they have to wear that continuously for a week once the mastoid dressing comes off. And I usually don't have them go to school during that time. And then after that, I have them wear it at night for a month. And I also put them on antibiotics for 7 days afterwards.
Like oral?
Oral, I put them on Keflex.
Like Keflex, okay.
Yeah. I have anesthesia, give them Keflex, and then I put them on Keflex just because I'm paranoid and young and don't want anything to happen. But I'm very open to suggestions and everything. So Charlotte, what do you do for your dressing and your post-op course?
I admit I also put antibiotics. That's really bad. That's really, really bad. It's not, the anesthesiologist every time say, but it's not recommended. And why do you do that? I just say, I'm too scared. I don't want to have complication periconditis. And I see all the second cases, complicated cases from abroad that are coming to a referential center. So maybe that's why I'm not changing. But I should maybe. I don't know. I'm not. Maybe I'm not ready. I'm not ready. But I give Augmentin, that's amoxicillin and acid clavulanic, for 5 days. But I think that for dressing, there are as many dressing as there are surgeons. So for me, I put a big dressing on the ear to press the mastoid, but it stays like 3 hours because I take it out before they go out. And I just tell them to bring a headband, but I don't want the one that are really tight. I really want something that is cotton and really that can breathe. And so I ask them to put it like 24 hours for a day for 8 days, and after only at night for 1 month. And I see them after 1 week, so I can see if everything is okay. And I tell them that if there is something wrong, if the color is not good, it hurts, or it's bump there behind the ear, like hematoma, they have to come right fast to the hospital.
Similar for me. And then do you see them after the initial post-op? What's your...
Usually that's the nurse that see them at 8 days, and I see them at 3 weeks.
I see them back sort of 1 to 2 weeks after, and I have them send me a picture if there's anything, wrong, and I give the same counseling, and then I see them back after 3 months.
For the other ear deformities, like Stahl's ear or Cryptotia, where you do have a potential for a bolster, how long do you guys keep that on for? Is that like a week?
Yeah. If I put a bolster, I usually keep it 1 week. The nurses take it out and they send me a picture, and after I see them 3 weeks after, so after the surgery, so I can put the mold if needed.
And is there any role for wound care or ointments or anything like that you recommend to the families?
If there is a bolster, they put like cream ointment on it with antibiotics, but after I just tell them they can put if they want to, but
so for prominent ear, there's really not like ointments or anything?
No, nothing for prominent ears.
Yeah, I just generic scar care stuff for me, but like the prominent ear scars like becomes in the sulcus, so like who really cares about that? But I tell them to keep it moist. Aquaphor, if they I just have a generic dot phrase like Aquaphor. You have your silicone sheeting, SPF, keep it out of the sun.
In terms of complications, we have like early and late, and we'd mentioned the concern for perichondritis. That's an early one. That's why, the antibiotics we're doing. But let's talk about some of the potential for complications and how you manage them.
Yeah, I think, as I said before, the biggest complication is dissatisfaction. And I think one way to kind of manage that, I found as I started this, is because we are in communication and it is like this healing process. You sort of, well, you're still going to heal, and I'll see you in 3 months. And then by that time, I think most families have sort of gotten used to it and are actually pretty appreciative. And so I could sort of defer, the initial like, oh my God, it doesn't look, I was like, oh, well, we'll see, it's still healing. And then, most families are pretty accepting of it. Of course, like you're afraid of infections, which is why we're running the antibiotics. And thankfully, I haven't had any big, at least for otoplasty, like infections or wound dehiscence or anything like that. But if you have any suspicion of that, you might have to take them back to wash it out or to sort of do some wound care there. As we are refining our microtia clinic at Rady, and we're training up our physician assistants to help with the wound care. Maybe in the future, I'll also have the otoplasty patients get their bolsters cut out by the microtia team. But right now, I'm doing that. And yeah, also, I think wound care is, especially for bigger reconstructions, is a big thing. You do want to really stay on top of it. I make sure that the families, I still try not to give out my personal cell phone number, but I do when I'm worried about things, so families can send me pictures. And then I make sure that the families have access to, we call it My Chart in our EMR, so that they know how to upload pictures and for our team to see them too. So that's sort of my...
And a question, how long would you wait before do a revision surgery if the family is really, really not, and the kids is really not happy with the ear result?
I would say minimum 1 year.
Yeah, I would do the same. So maybe he can change his mind.
Yeah, exactly. Time really,
time heals. Yeah, time and reassurance, yes. Yeah, I think that for me, that complication, hematoma or infection, that's an issue, but hopefully, and I always tell the parent what to do, and for the moment I never had in my patient problems, but it can happen anyway. I think that the most problem is keloid, to deal with keloid in teenagers. And for that, I follow them really a long time, meaning that 1 year after the surgery, I see all of them to check if everything is okay. I ask them to send me pictures if they see that the scar is moving, is bumping, is scratching, itching, so I can do corticoids if needed. And for teenager, I didn't mention that, but I always tell them that there will be pressure therapy on the scar, like for 3 months, 24 hours a day. They put a small adhesive silicone bandage that will pressure the scar, so to prevent keloids.
So you do that for every teenager.
Yeah.
The silicone strip.
Yeah, every teenager, or when they are younger, for Black, Asian, or any type of skin that are more known to do hypertrophic scarring.
Wow. And you do that every day, 24 hours a day, for how long?
Yeah, as it's really thin and you don't see it, so I ask the parent to put it, leave it, just the time it stays, and after, when it comes out, just change it. And they
for
can
a year?
Yeah. But no, for 3 months.
3 months. That's great to know. I haven't heard that before.
It's a tape?
Yeah, it's not a tape. It's called...
like silicone sheeting?
Yeah, it's kind of silicone shield. There are several kind of, and the one we use is not that expensive, and they can find it. It's there in big sheets, so I teach the parent how to cut it. So in one sheet, they have several part they can use.
I should start considering that. I mean, that's a really good point. I had, in general, have been avoiding silicone sheeting just because, like, a lot of families, especially for younger children, because Charlotte's like, this is more for teenagers, so it makes sense. They're going to rip it off, especially if it's like a more obvious part of their face. And so I always tell parents to do the silicone ointment and then massage the ointment in like twice a day. And then these like silicone products, like there's, as Charlotte was saying, there's like this variety of price points. The one that a lot of adult cosmetic people use, and this is on Amazon and in the US, is Biocornium. It is like it also has SPF in it, and it is like a silicone scar cream. A very small bottle of it is like $75, but like when my daughter got a gash on her head, I was like, oh my gosh, I get the Biocornium. But that might be not possible for like a lot of my patients. And so what I tell people in my practice is like, get whatever 100% silicone ointment from Amazon, from the drugstore, for the purposes of scar creams, and you can find a lot of products like Mederma for under $20, and it could be pretty accessible. But I think probably the same goes for the silicone sheeting, and it might be a really good point to do that for the adolescents behind the ears especially. So thank you.
When do they wear their glasses again? When can they play sports? Some of those types of, what are those recommendations?
I say 1 month for everything. Yeah.
Wow. So that must be tricky if you have a 8-year-old that wears glasses. That might be something that
it can put like maybe gauze on the ear and put the glasses, or they can go to the l'opticien, so they can revise the branch of the glasses so it won't touch the scar.
Yeah, I'm not as tricky about glasses because I don't know, I've just been like put them on because I think it would be hard, but I do also say no sports as long as that headband is on. And then it also sort of goes to the point about cooperation, right? Like if you feel like if you're counseling the family about what the aftercare is like, and if they don't think that's going to be possible, then we're not ready yet.
And PE and sports, is that a month as well, or 3 months, or?
No, after 1 month, I think.
1 month.
If they want, they can put the headband during sports session.
I say definitely no contact sports for a month. And again, this is all it's just voodoo, I guess, I say no contact sports for a month. Kid was like, but what about golf? And I was like, well, maybe after 2 weeks, I don't know.
Yeah.
Right. So as we start to round it out, can you tell us if there's any, upcoming directions or innovations or what you would like to see in the future, or any final pearls that you'd want to leave us with?
Conceal. Yeah. Just choose the patient and just do the surgery if the child is ready. Not for the parent, but really if he wants to. I think it's a good tip to avoid trouble.
Yeah, I would say the same. I learned a lot from Charlotte. I learned about her scar management, and I'm interested in, her Cryptotia, technique and the draping technique. And I think otoplasty is a really challenging surgery. I mean, I had great training in it, but now in my independent practice, I'm still learning with every case I do, and every follow-up at every time point. I'm like, oh, I maybe could have done this better, and it's hard to say. So it's a lifelong
journey.
Learning.
Yeah.
Journey. Yeah.
Yeah, Jason is right. I can think that every ear is different. Every patient is different, and I'm still changing to my techniques. If I see something incongruous, I say, I will try that, and if the result is okay, I keep it. Some point of it still evolving. Yeah.
That's awesome. Well, thank you so much. Thank you for co-hosting with me, Jason.
Thanks for having me.
And Charlotte, merci beaucoup. Thank you so much for your time and sharing your experience.
Merci beaucoup de m'accueillir.
Thank you so much for listening. If you haven't already, make sure to subscribe, rate the podcast 5 stars, and share with a friend. If you have any questions or comments, direct message us at _BackTable ENT on Instagram, LinkedIn, or Twitter. BackTable ENT is hosted by Gopi Shah
and Ashley Agan.
Our audio team is led by Qian Gannon, with support from
Aaron Bowles,
Gabe Lagrezio,
and Josh Spencer.
Design and digital marketing led by Brian Schmitz, with support from
Taylor Spurgeon Hess.
Social media and PR by Chi Ding.
Administrative support provided by Judy Dela Cruz. Thanks again for listening and see you next week.